everybody on time and finish on time. Good morning, everybody, or good afternoon, or good evening if you are in Egypt. I am Osama Tawfiq, a pathologist, professor, and chair of pathology at St. Luke's Health System of Kansas City, and the current president of the Society of Egyptian Pathologists in North America. I welcome you to our lecture series for the Society. Before I introduced our featured distinguished guest speaker, I would like to remind you about a few housekeeping items, so please consider them. Please mute your speakers and turn off your videos. I know all of you so far are doing that, and I appreciate that. Questions will be sent through the chat box found on the right of your screen. The moderator will try to share them with the speaker at the end of his talk. This lecture, as well as all the other lectures, are going to be recorded and uploaded on the Society's website, as well as the YouTube channel of the Society. So you will have access for them for your convenience and future reference. Very importantly, we appreciate your feedback to improve our experience and appreciate your comments about your interest in certain topics that you would like us to cover in the future. Without further delays, I have the privilege of introducing Dr. Hany Meawad. Hany is a graduate from Qasr Al-Aini. After graduation, he started his anatomic pathology residency at Ahmed Maher Teaching Hospital for 2 years, then went back to Qasr Al-Aini, where he joined the teaching faculty as assistant professor in anatomy, embryology, and neuroscience till 2016, from 2007 to 2016. In 2016, he moved to the United States to start his residency in anatomic and clinical pathology at the University of Toledo Medical Center in Toledo, Ohio, for 3 years, then moved to UCLA to finish his residency. From there, he went to the City of Hope in California to start his HemePath Fellowship for 2 years. After fellowship, he went back to academia and started as an assistant professor at the University of Arkansas with HemePath services. After Arkansas, he saw the light and decided to join the private practice world, and he's currently in California practicing as a hematopathologist and surgical pathologist with HemePath expertise at Victorville, California. The title of his presentation that he gave me was Mast Cell Disease, an Overlooked Entity, but you will see on the screen he has a fancier title that I like. Without further delays, Dr. Meawad, please feel free to start whenever you want.
Thank you, Dr. Tawfiq, for the wonderful introduction. I'm going to discuss today the mast cell disease, or we call it mysterious cell disease, because it's commonly missed in diagnosis, and a lot of people miss this entity while looking at bone marrow. So let's start with just warm up with the clinical vignette. So we have a 31-year-old female presented with marked pancytopenia. She has a history of acute myeloid leukemia with translocation 821, and she is on chemotherapy. And here are her blood counts. As you can see, she is pancytopenic. This is her bone marrow. Bone marrow is kind of infiltrated with these sheets of blasts, and we can see them very well on the aspirate smear, and CD34 also highlights these blasts. So the case was signed out as persistent acute myeloid leukemia. The patient has around 60% blast in hypercellular marrow. There's some dysgranulopoiesis, and the patient has history of acute myeloid leukemia with translocation 821, and she's on chemo. And doing the NGS or sequencing, we found these kind of mutations in her bone marrow, like the RUNX1, the 821 mutation, and other mutations. In addition to this, we found some other variants of undetermined significance or uncertain significance, VUS. One of them includes the KIT mutation. 4 months later, after receiving chemotherapy, the patient bone marrow is kind of ablated, as you can see, and we don't see the leukemic cells anymore, but we start to see these kind of groups or spindle cells going on in the bone marrow. And these spindle cells, if we look at the aspirate smear, we can see the darkly basophilic cells with tons of granules. They start to pop up. We did the C34 to see the blasts, and there is no actual blasts in here, so blasts are gone. So the patient is responding very well to treatment of acute leukemia. However, CD117 is kind of bright, strongly bright in this case. So what are these cells? Are they blasts? No, they are not blasts. They are 34 negative. And they're bright CD117. They're not weak or moderate. They're bright. That's a key here. Mast cells are usually bright for CD117 or c-KIT mutation because of the c-KIT mutation. When we did the mast cell tryptase, they highlight these cells, and CD25 shows an aberrant expression of these mast cells. So that's probably there's mast cell disease going on. So the diagnosis of that case is hypocellular marrow with reduced trilineage hematopoiesis, and there's mastocytosis going on. There is no evidence of residual acute leukemia. The acute leukemia is gone, but the mast cell disease start to show up. So here we can see there's multifocal aggregates. These spindle cells, they're interstitial infiltrates of atypical mast cells consistent with systemic mastocytosis with associated hematologic neoplasm. So what probably happens is the patient has an acute myeloid leukemia, but these mast cells at the same time, mast cell disease at the same time, when there's a combination of mast cell disease and myeloid neoplasm, we call it systemic mastocytosis with associated hematologic neoplasm. Initially, when the bone marrow was extensively involved by leukemic blasts, we were not able to see these mast cells. They were masked by the extent of the blasts involving the marrow. After the blasts are knocked out by giving chemotherapy to the patient, the mast cells start to be uncovered or unmasked. So a little bit about mast cells. Mast cells can look a little bit like basophils, but there are certainly differences, including the size. Mast cells are way bigger than the basophils. These are oval, these are rounded in shape. They are densely packed with granules. As you can see, they are very dark and bright, and their lifespan extends for months. These are the stains we usually use for differentiation between mast cells and basophils because they can look alike. So tryptase is really important in mast cells, and it's kind of very specific. CD2 and CD25, these are important for neoplastic mast cells. CD117 is the take-home message today, or c-KIT. This is bright. It should be bright. CD117 stains a lot of things in the bone marrow. Early erythroids can stain with CD117. Early myeloid cells can stain with CD117. But they are usually weak in intensity. Mast cells are very bright in intensity. So every time you do bone marrow, don't forget to do CD117. If it's very bright and scattered cells, that's fine. There's scattered mast cells. But if there's forming aggregates, you should worry about mast cell disease. And here are some differences in the markers which we use for systemic mastocytosis, which is a malignant disease. We see these CD20, CD2, and CD25 are being the most characteristic for neoplastic mast cells. They're very important here. Versus normal mast cells, they usually should not express CD2 or CD25. So CD2 and CD25, and most recently in the latest WHO classification of hematolymphoid neoplasm, they added CD30 as a diagnostic markers as well. So CD30 is now being introduced to the mast cell disease. Some other histopathologic findings we can see with tissue infiltrates of mastocytosis. We can see fibrosis, angiogenesis, osteosclerosis in the marrow. We can see eosinophilia, lymphocytosis, or plasmacytosis. I don't want you to bother yourself about the older classification of mast cell disease where they call it systemic or localized in the skin. We call it cutaneous mastocytoma or other places, because all these kind of classifications are kind of all from 2001, but right now we have different classification. And this is the most recent kind of classification of mastocytosis. So mastocytosis could be just cutaneous in the skin only, and it can present with urticaria pigmentosa or maculopapular cutaneous mastocytosis, or it could be diffuse rash, diffuse cutaneous mastocytosis, or it could be localized as mastocytoma of the skin, or it could be mast cell sarcoma in other different organs, or systemic mastocytosis. Systemic mastocytosis is the entity that does have a lot of subtypes, including the most indolent form. We call it indolent systemic mastocytosis. That's a bone marrow, including the bone marrow mastocytosis type, smoldering type, systemic with associated hematologic neoplasm, or aggressive mastocytosis and mast cell leukemia. So to start with the first one, which is cutaneous mastocytosis, they should have skin lesion demonstrating the typical features of either solitary mastocytoma or urticaria pigmentosa or diffuse cutaneous mastocytosis. And it should also have typical histologic infiltrates of mast cells in a multifocal or diffuse pattern in adequate skin biopsy. And also features or criteria sufficient to establish diagnosis of systemic mastocytosis has to be absent. So this is an exclusion criteria. So if we have mastocytosis in the skin, and in addition, we have mastocytosis elsewhere, so that kind of exclude the diagnosis of cutaneous mastocytosis is systemic. To call it systemic mastocytosis, we have to have these criteria. The major criterion is multifocal dense infiltrates of mast cells, and we have to have at least 15 mast cells in aggregate in sections of bone marrow or other extracutaneous site outside the skin, because that's a systemic variant. And then we have minor criteria. Minor criteria includes in biopsy section of bone marrow or other extracutaneous sites, we have to have more than 25% of the mast cells are spindle-shaped in a core biopsy, not in a smear, or having a typical morphology. More than 25% of the mast cells in the aspirate smears are immature or atypical. Another minor criterion is the detection of KIT mutation, the 816 codon mutation, and this was the original mutation. But right now, with the introduction of the latest classification by WHO, they trying to include any KIT mutation as an acceptable criteria, minor criteria. Mast cells in blood or bone marrow or other any organ outside the skin that expresses CD25 plus or minus CD2, and right now they are adding with the newest classification CD30. Serum tryptase level is more than 20 nanogram per milliliter persistently, unless there is other myeloid neoplasm which can make this criterion invalid. To call it systemic mastocytosis, we have to have one major criterion and at least one minor criterion. Or if we don't have the major, we have to have at least the three of the minor criteria. So, and then we have B findings, which includes the burden of the disease. This is organ involvement, but no dysfunction. Organ involvement like hepatomegaly without liver dysfunction, splenomegaly without hypersplenism. High mast cell burden, including more than 30% infiltration of cellularity by mast cells, focal aggregates in the bone marrow, or serum tryptase more than 200, not just 20 nanogram per milliliter. Signs of dysplasia or myeloproliferation in non-mast cell lineage, other cell lineage like erythroids or myeloid, but criteria should not be definitive diagnosis for associated hematologic neoplasms. C findings, cytoreduction requiring organ involvement, and this one should include organ dysfunction. Organ dysfunction is defined as, in bone marrow dysfunction, one or more cytopenia with these numbers. Absolute neutrophil count should be less than 1, hemoglobin less than 10, platelets less than 100, palpable hepatomegaly with impairment of liver function and or portal hypertension, palpable splenomegaly with hypersplenism, skeletal involvement with large osteolytic lesions in the skeletal survey, malabsorption or weight loss due to GI mast cell infiltrates. So C criteria or C findings are organ dysfunction. General criteria of systemic mastocytosis. If there's just all these criteria without nothing else, we call it indolent systemic mastocytosis. If we have bone marrow involvement, we call it bone marrow mastocytosis. If we have 2 or more B findings plus high mast cell burden, we call it smoldering systemic mastocytosis. If we have another hematologic neoplasm like MDS or AML or lymphoma or any other neoplasm, hematologic neoplasm, doesn't have to be myeloid, could be lymphoid. We call it systemic mastocytosis with associated hematologic neoplasm. 1 or more C finding, we call it aggressive systemic mastocytosis because there is organ dysfunction. Bone marrow biopsy shows diffuse infiltration, usually dense, by atypical or immature mast cells, or bone marrow aspirate more than 20% mast cells. We call it mast cell leukemia. What about mast cell sarcoma? Mast cell sarcoma is an extremely rare entity where is localized destruction by a highly atypical or malignant anaplastic mast cells, which can be identified only by IHC because they don't look like regular mast cells. Natural history, usually there's terminal phase resembling mast cell leukemia. The patient usually have very short survival month, and it can include different organs like larynx, large bowel, meninges, bone, or skin. Differential diagnosis of mastocytosis. It could be just a non-neoplastic process, which we call it mast cell hyperplasia, or it could be myelogenous tumor with some mast cell differentiation, but lacking the criteria for systemic mastocytosis, like MDS or other stuff. Or it could be tryptase positive AML, or AML with KIT mutation. But here we don't see the compact infiltrates of mast cells, or mastocytosis or mast cell disease, where we have typical skin lesions. What are the types of hematologic neoplasms we usually see in associated hematologic neoplasms? So there is definitely different types, including myeloproliferative neoplasms and chronic myelomonocytic leukemia, myelodysplastic syndrome, and acute leukemia. And these are different studies that has been done on 342 patients and 123 patients with systemic mastocytosis with hematologic neoplasms. And this is the breakdown of the types of neoplasms that can happen with systemic mastocytosis. So as we see, the vast majority of hematologic neoplasm are myeloids, and the rest are either lymphomas, myelomas, plasma cell neoplasms, CLL, or primary amyloidosis. And out of these myeloid neoplasm, they are broken down into myeloproliferative neoplasms, chronic myelomonocytic leukemia, which is a huge proportion, myelodysplastic syndrome, or acute leukemia. And then here the clinical and laboratory characteristics are diagnosis of systemic mastocytosis associated with associated hematologic neoplasms. These are the different characteristics. Leukemic transformation, usually it happens only in around 11% of patients with myeloproliferative neoplasms, 6% in CMML, 29% with MDS, definitely acute leukemia, they already presenting with leukemia. And this is the absolute eosinophilic count in these different types of patients. And this is the overall survival group. Which one has the worst prognosis? Systemic mastocytosis with acute leukemia definitely shows to have or present with the lowest survival, as you can see on this graph. Myeloproliferative neoplasm has the best prognosis, and better overall survival. And then the two types in between, the CMML and MDS, are in between categories. Why this designation, systemic mastocytosis with associated hematologic neoplasm, is important? So to answer this question, we can split the answer into two different questions. What if I miss the hematologic neoplasm component? I just call it systemic mastocytosis and I forget, or I missed hematologic component. And the other way around, what if I miss the systemic mastocytosis? I just call it hematologic neoplasm and I forget about the systemic mastocytosis, exactly like the first case I started my presentation with. So here are the differences. What if I miss a hematologic neoplasm? So here, this is systemic mastocytosis alone, this one, and this one was associated hematologic neoplasm. And we can see the great difference in the survival for the two different patient categories. Definitely, patient with associated hematologic neoplasm has much worse survival as compared to just systemic mastocytosis. And these are the different subtypes of mastocytosis. What if I have just indolent? They have the best survival. Aggressive form, they have worse survival. But if I have an aggressive or associated hematologic neoplasm, it would have the worst survival of these three categories. What about if I miss the systemic mastocytosis component? So here we have, like, this study has been done to compare the survival between the patients with CMML patients and patients with CMML with systemic mastocytosis. As we can see, the difference here, there is worse survival in patients with CMML and systemic mastocytosis. So if you miss this part, that's really it makes it a big deal, because you are affecting, like, you are missing an important component which adversely impact the survival of the patients. And we can see here there's some dysgranulopoiesis in patients with CMML, and we can see that tryptase highlighting these mast cells. We can see also in this study, they looked at the hidden mast cells in patients with acute myeloid leukemia with translocation 821. So this particular study has been performed on patients with acute myeloid leukemia with 821 that have some hidden mast cells. And they found out 4 patients met criteria for systemic mastocytosis. 1 has myelomastocytic leukemia, and 8 patients has just benign mast cell hyperplasia, and patients with AML with 821 translocations. And these are the different KIT mutations seen in these patients. These are the 4 different patients with systemic mastocytosis with AML. These are the different KIT mutations. So now, how does this happen? How can the patient has 2 different clones? Systemic mastocytosis as one clone and new hematologic neoplasm as another clone. So different theories discuss this. One theory said that we can have 2 separate clones. One have the KIT mutation that's responsible for systemic mastocytosis, and another one has the mutation that are responsible for hematologic neoplasm, like RUNX1 mutation or SRFS2 mutation. Or it could be the same single cell, and it does have the 2 mutations in it, and it then divides like this. So it could be 2 separate clones, or it could be a separate cell, the same cell with same clone, but have 2 different types of mutation. Or it could start with the mutation for hematologic neoplasm, and then this clone acquires later on a KIT mutation. Or it could start with the hematologic neoplasm mutation and then acquire KIT mutation in one cell line, and another cell line accumulate another mutation like FLT3 mutation with hematologic neoplasm. So what is the role of the KIT mutation in the development and biology of the mast cells? So here's the stem cell factor. It activates the KIT on the extracellular domain here, which starts cell signaling, and it causes the proliferation and survival of mast cells. And for mast cells to generate or to divide or proliferate from its progenitor cells, the hematopoietic stem cell progenitor or granulocyte myeloid progenitor cells, or basophil mast cell progenitor cell, they have to acquire the KIT gene activation to go into this line mast cell rather than to go into the basophil lineage. Because basophil and mast cell, they originally arise from the same cell, which is called basophil mast cell common progenitor cell. If it does have an activation of the KIT, it will divide into mast cell. If it's lacking it, it will go into basophil. So this study has done some KIT mutant mice or knockout mice. So they removed the gene responsible for the KIT gene, and this is what happens. If we play with the gene responsible for the KIT, this is the wild type KIT, and if we removed it or absent KIT, the mast cells shrink or die, they do not proliferate. And if they activated this KIT, it will increase the number of the mast cell and can cause mastocytoma or malignancy of mast cells. So the most important take-home message is the KIT is the most important thing in mast cell development, activation, proliferation, and survival. Loss of KIT, absence of mast cell. Activation of KIT, tumorigenicity or proliferation of mast cells. These are different studies that has been done in the past in 2014 and 2015 about different types of, this is the KIT gene, and there are three different parts of it. Part is extracellular domain, part is juxtamembrane domain, and part is intracellular domain. And they found that different mutations can happen in the KIT gene can lead to mast cell proliferation and disease. And this has been done a lot of studies. The vast majority was in this exact codon here, the D816V mutation, and this is mostly 90% of adult systemic mastocytosis case, and one indolent systemic mastocytosis to mast cell leukemia, and 35% of the children. So this is the most important mutation. However, this study also found a lot of other KIT mutation that does happen outside this D816V mutation. So in the past, I think I presented the same presentation a few years ago before the newest classification of WHO for hematologic neoplasm, and they only certifies this particular mutation to call it as a minor criterion. Right now, because they discovered a lot of other mutations in the KIT gene, so they included any KIT mutation in the systemic mastocytosis minor criteria. And these are just lists of different KIT mutations that can be seen in systemic mastocytosis and their frequency. What is the frequency of KIT mutation in systemic mastocytosis? So to answer this question, frequency of KIT mutation in systemic mastocytosis, what is the frequency in different compartments of the bone marrow hematopoietic stem cells and in different diagnostic categories? So this study has been done on by Spanish network of mastocytosis on a series of 113 patients. And they showed this is the frequency of KIT mutation. We can see in indolent systemic mastocytosis, definitely the KIT mutation is present in 100% of the mast cells, but it can also be present in hematopoietic stem cell, the CD34 positive hematopoietic stem cells, 24% of them, 21% of eosinophils, 11% of monocytes, and 8% of neutrophils and 10% of lymphocytes. So the KIT mutation can be present in different compartments of the hematopoietic stem cells in the bone marrow. In patients with systemic mastocytosis with associated hematologic neoplasm, it also can happen in different compartments, and these are the breakdown of the frequency of this mutation in different bone marrow compartments. Here is the systemic mastocytosis demographics and clinical characteristic of study population according to disease category. So here, they found that the KIT mutation just before treatment, they have done it in almost 100% of patients with mast cell leukemia and indolent systemic mastocytosis, and in patients with well-differentiated systemic mastocytosis. This study is a very interesting study that has been done in UCLA. What they found, they did targeted FISH analysis on mast cells. So this is a particular mast cell in the bone marrow. And they highlight these mast cells with tryptase, and they found the RUNX mutation, RUNX1, RUNXT1 mutation in the bone marrow, which is a patient with AML. So the same cell, that's neoplastic cell of AML, was translocation 821 or RUNX1, RUNXT1 mutation, has the a KIT mutation in it. So the same cell or same mast cell harbor the two mutations. So is there any other concurrent mutations other than the KIT mutation, systemic mastocytosis? Yes, there are some mutations that can happen along with the KIT mutation in patient with systemic mastocytosis. And this is the breakdown of these other mutations, which when we do the myeloid NGS panel, we can see all these kind of different mutations that can happen with patient with systemic mastocytosis. So the data of indolent systemic mastocytosis says just presence of KIT mutation by itself can lead to systemic mastocytosis. If we acquire new genetic defects, it can lead to systemic mastocytosis with associated hematologic neoplasm. And then we have two different disease entities or categories: systemic mastocytosis and associated hematologic neoplasm. Could be MDS or MPN or other types of hematologic neoplasm. The last thing to conclude this presentation is how to test for KIT mutation. Is there any consensus on how to test for it? What is the most sensitive test? Can we detect it in peripheral blood leukocytes? And what are different assays? So this is just comparison between different methodologies, molecular methodologies we usually use to detect the KIT mutation, and these advantages and disadvantages of the different types. So for reverse transcriptase PCR with restriction, fragment length, polymorphism, this is the simple, fastest, very reliable, very cheap. But the problem, it detects only the KIT mutation with the D816 mutation. And it's not quantitative, just tell you absent or present. So it's just qualitative and not quantitative. It cannot tell us exactly the amount of or the burden of this mutation. Nested PCR, this one detects different types of KIT mutation, because right now we know that 816 is not the only one of KIT mutation that's present in systemic mastocytosis. But the problem is low sensitivity and it's not quantitative. PNA mutated PCR, it allows detection of KIT mutation at 816 or other sites, so that's good. And we can do it also in tissue blocks, doesn't have to be done on fresh tissue. But again, the problem is not quantitative, and its sensitivity is not that the best, it's just intermediate. Allele-specific oligonucleotide qPCR is simple, fast, cost-saving, and it's highly sensitive. That's good. And it's quantitative as well. So it can tell you the tumor burden or allele burden of this KIT mutation in bone marrow. So we can use it for follow-up. If we have a patient today is diagnosed with systemic mastocytosis, and the patient received treatment, after treatment, how about the allele burden or the mutation burden after receiving treatment? Is the mutation level going down or going up, or is the patient responding or not responding to treatment? But the problem is it only detects the 816 mutation, and it still needs standardization, validation, harmonization among the labs. So this is the problem. But sensitivity is it's quite sensitive, and I should say the most sensitive. So the take-home message from this presentation, when you look at the bone marrow, looking for anything, including acute leukemia or myeloproliferative neoplasm, you usually start with CD34, and you do CD117, and you do another erythroid markers like 71 or E-cadherin. Closely and carefully look at CD117. If it's weak, okay, so that's fine. These are just the early erythroids on the and myeloid cells in the background. If it's strong and bright, you got to be very careful. Are they just scattered few cells here and there? That's fine. If they are forming aggregates, stop and pause for a moment and think of CD117 is the other name for the c-KIT mutation. Think of CD117 and mast cell disease. If it's bright and making nodular aggregates in the bone marrow, think of systemic mastocytosis. And you have to work this up and to see what kind of mastocytosis is it just bone marrow mastocytosis? Is it systemic? Is it aggressive? Does it have B symptoms or C symptoms? And this is I guess, the take-home message. And by this, I'd like to share my references here, and I would like just to thank you all for listening and for giving this opportunity. and I'm happy to take any questions.
Well, great presentation, Dr. Meawad. Thank you. Thank you so much.
Thank you, Dr.
I learned a lot personally, although I'm not a hematopathologist. I claim to be a part-time hematopathologist when my hempath people are not around me. And the floor is open for questions if you guys have any.
Hello, Hany. Thank you so much for this presentation. It's really great. This, Muhammad. I just want to double check on weak versus bright. Are you yes? This is a very important point that you mentioned. Is it? I'm a hematopathologist. I'm a hematopathology fellow now. So, are you referring to the stain, or are you referring to the flow cytometry, or both?
Both, actually. That's a really good question. So it's both. CD117, you can see here, like, let's say, for example, let me share my screen here. Okay. So you can see these CD117 in this picture. You see how bright it is?
We're not seeing the screen.
Oh, sorry. So let me go back.
I'm not seeing your screen,
Okay,
Hany.
so let me just share it back again. Okay. So I get to share. Okay, how about now?
It's coming. Yes.
Okay. So this is the, yeah. You see here, this is the CD117. It's very bright. You can tell, like, from this picture and the picture below it. See, this is kind of weak intensity and this is bright intensity. The brighter intensity, and if you do it in the bone marrow, you would definitely can use it as, even we use the mast cells as an internal control to see if the CD117 is working or not. So we typically have rare or few mast cells in our bone marrows, right? And you can tell them the strong intensity versus weak intensity. And also in flow cytometry, it's a very good tool. You know, CD117, you should see it sky high up in the flow plots versus CD117, which we can see with other leukemic cells or erythroids or other stuff. So CD117 is very bright in both IHC and flow cytometry.
That's very important. Thank you very much, Hany.
Sure.
Okay, I have a stupid question.
Oh, no.
I learned no question is a stupid question. I'll make a fool out of myself. I'm comparing now, I think, with gastrointestinal stromal tumors. We use CD117.
That's right.
We use DOG1.
That's right.
Does DOG1 work on mast cells?
No, it does not. Because DOG1 is as the name implies, is discovered on just DOG, discovered on just. This is kind of very specific for gastrointestinal stromal tumors. It does not stain the mast cells. And also mast cells, we can do tryptase. Tryptase stains only mast cells. So that's very helpful, you know. So tryptase, but the problem, tryptase stains regular or normal mast cells and neoplastic mast cells, but doesn't stain other cells. Like tryptase doesn't stain other hematopoietic cells or other tissue cells. So tryptase is kind of very specific. And that's why we call it mast cell tryptase. So you can just do mast cell tryptase and definitely, as you mentioned, DOG1 or C34, other markers for just mutation. But yeah, like the KIT mutation has been included in a lot of pathogenesis of a lot of neoplasm, including the mast cell disease and other disorders for sure.
I have one more question related to management, kids and adults. Does it make a difference? I know we're pathologists and we don't talk a lot about management, but I would like to know if you have any information about that.
I think it's the treatment mainly depends on the disease burden rather than the age, but they have specific treatment for systemic mastocytosis depending on the disease burden rather than the age. That's my guess, because as you mentioned, we don't typically treat patients, but they put them on chemotherapy regimes for systemic mastocytosis, depending on the aggressiveness of the disease. Is it just indolent, or is it aggressive, or there is other associated hematologic neoplasm? Let's say the patient has acute leukemia, so they are not just give him treatment for systemic mastocytosis alone. They have to knock out the leukemic cells using chemotherapy regimens for the acute leukemia.
Excellent.
Can I ask another question, please, Osama and Hani?
Sure.
Thank you. So, Osama, I want to double check also on the CD117 again, because we literally have a case that we are suspicious of it. So you do CD117. If CD25, and you are suspicious based on the aggregate that you are seeing at the mast cell, but you are suspicious and the CD25 is not showing anything, are you still taking it to molecular, or you stop right there, or you do like CD2 and stuff?
Actually, yeah, that's a really great question, because
Yes.
CD25, sometimes I feel from my personal experience, it's really hard to interpret. It does show a lot of
Yes, exactly.
meaning. So I would rather do CD2 and CD30. CD30 works very well. CD30 in the bone marrows, it shouldn't stain a lot of cells, right? So CD30, we use it either if it's a Hodgkin lymphoma going in the marrow, or there's mastocytosis. Not much. No other things you can do like should show up with CD30 in the bone marrow, right?
Mm.
Because and you have to make sure that the control is working, because sometimes the control is weak and it's not
Yes.
reliable. So
Mm.
you have to make sure the control is working well. And if you would like to do CD2, and if you would like to do the CD30, that would be extremely helpful. And also, just to cover your bases, you gotta do the KIT mutation analysis.
Mm. Mm.
If the patient is presenting with other hematologic symptoms, like you're suspecting MDS or MPN or other hematologic neoplasm in the background, you probably want to do the NGS profile, correct?
Yes, yes, because the one that we have is exactly what you mentioned. He's a patient with another AML. We treat him. However, when we set the molecular for that AML, now we are seeing a kit, but at the low VAF, very low VAF.
Uh-huh.
We looked back at the CD117, exactly what like how you described this. Describe. We looked back and literally we saw a group of cells that is spindly at the very edge. The bone marrow itself biopsy was not that helpful. However, we saw those groups. After we saw those groups, we returned back to the CD117 to highlight those groups. We did 25 on top of them. The
Mhm.
top of 5 was not helpful. So we are in that, and tryptase is just gonna show you whether it's normal or So, but that's good. That's good point that you mentioned about CD30. That's something I didn't know.
Yeah, and also remember mast cell tryptase, the tryptase itself, in the normal bone marrow, it should show the mast cells are kind of single scatter cell. They should not form aggregates or groups,
Okay.
right? So being in a groups or being spindly or atypical morphology, that's one of the criteria.
Okay.
So making an aggregates,
Mm.
it by itself is a criterion.
That's a criteria. Okay. Thank you.
Sure.
Well, thank you again, Hany,
Sure.
for
Thank you.
outstanding lecture.
Appreciate that.
And thank you, folks, for attending the lecture. Please remember that we will have lectures every first Saturday of every month around this time. And I look forward to another outstanding lecture, everybody.
Dr. Taufik, I raised my hand. I have a question.
Oh, sorry, I missed that. Please
Okay.
go ahead.
Okay. So my name is Jailan Osman, and I'm a pathologist in South Carolina. So my question is, so you talked about multiple immunostains. So do you suggest a panel that we can do every time? Just a panel for us. So when we think about mastocytosis or like that, so any panel you
Yeah.
suggest?
So, for like I don't want you to exhaust the block in unnecessary stains, right? Because you
Mhm.
want to preserve it. Because bone marrow, we do bone marrows for sure for
Yeah.
we are suspecting leukemia or MDS or MPN or staging marrow for lymphoma, right? So you
Mhm.
probably want to start to
Reflex,
yeah.
something reflex.
Yeah, I mean, no. I mean, let's say you are suspicious for systemic mastitis. You see nodular aggregate of spindle cells in the bone marrow, and
Uh-huh.
that it doesn't look like a granuloma to you, right? It
Mhm.
looks aggregate of spindle cells, and it doesn't look like a granuloma, or you are not
Mhm.
suspecting a granuloma. So now you're thinking of mast cells. So you do the CD117. I think this stain by itself is enough to tell you if there's mastocytosis or not.
Uh-huh.
But definitely you run other stains. Let's say we have a bone marrow for follow-up of myeloma. You do the CD138 and kappa lambda, right? So it
Mhm.
depends on the scenario, right? If it's a staging marrow for lymphoma, so you see what kind of lymphoma they are looking for, and you do the panel of stains for lymphoma. But
Yeah.
if you are morphologically suspecting mastocytosis,
Yeah. This is what I'm talking.
nodular aggregate of spindle cells in the bone marrow, oh, now we have to add the CD117.
So
If
you
it
do
if it's
CD1.
strongly positive, you can further
Mhm.
pursue it. You can do tryptase, you can do CD25, you can do CD2 and CD30. And I know not a lot of places do the CD2 and 25 as part of the routine panel. It's only in like certain reference
Yeah.
labs. Yeah,
Yeah,
but
I used to
yeah,
do CD117 and tryptase as the first uh, panel for me. So you want to start with CD17 only?
yeah, CD117 only is enough
Uh-huh.
because if you find only rare scattered mast cells here and there and they're bright in the bone marrow,
Mhm.
that's normal. That's
That's normal, yeah.
yeah. So we don't want to exhaust the block in
Uh-huh.
doing
Uh-huh.
unnecessary stain and just preserve it for more useful stain. What are you looking for depending on the clinical scenario you are facing? Is a cytopenia or cytosis or
No, no,
staging?
I'm talking about if you think
If
it
you
is,
think, yeah, if
yeah.
you see nodular aggregate, you start with CD117. If it's strongly, brightly positive, then you can run the other
Proceed.
stain like tryptase, CD25, CD2, or CD30 by the latest WHO classification.
Okay. Thank you very much. Appreciate it.
Sure.
Thank you. Excellent presentation. Appreciate that. Thank you.
Appreciate it. Thank you.
That's it from me.
Okay.
More
Thank you.
questions? Going once, going twice. See you, folks.
Okay.
Thank you,
Thank you,
Hany.
Dr. Tawfiq. Appreciate your time. Thank you, everyone.
Very good.
Have a good day. Bye-bye.
Take care, everybody.
Thank you.